Hello and welcome to the Spinal Cord Injury Forum. I'm Stephen Burns, Medical Co-Director of the Northwest Regional Spinal Cord Injury System. The forums, the video recordings, and our online media content are made possible by a grant from the National Institute on Disability and Rehabilitation Research. Tonight we are happy to have Dr. Rina Reyes talking about intrathecal baclofen therapy for spinal cord injury. Dr. Reyes is the Medical Director of the UW Medicine SCI Rehabilitation Program and an assistant professor in the UW Department of Rehabilitation Medicine. After her presentation, we will hear from panelists about their experiences with intrathecal baclofen. There will be time for questions after the presentations. Now please welcome Dr. Rina Reyes.
All right, thanks everyone for coming in this terrible weather outside. So you've braved all that, so I hope to give you a pretty good presentation. The design of the presentation is meant to give you additional information and overview about baclofen pumps, regardless of where you're at in considering a baclofen pump, or if you already have a baclofen pump, or if you're clinicians who are caring for individuals and working with individuals who have baclofen pumps. So there's a lot of information, so forgive me if we just try and go through these. In terms of an overview, we hope to answer the following questions, which is what is intrathecal baclofen therapy? What is it used for and how does it work? When should a baclofen pump be considered in the management options for spasticity? What are the advantages and possible disadvantages or side effects of using a baclofen pump? What is required to maintain the pump? Helpful hints for getting the outcome that you desire from baclofen pump and from spasticity management in general. And in the end, I'm really fortunate to be joined by hopefully 3 individuals who actually have had pumps implanted, and a physical therapist who actually has worked with individuals who have considered baclofen pumps and have had baclofen pumps implanted. So we hope to give you as balanced of a presentation as we can on this therapy. So what is an intrathecal baclofen pump? We also call that a baclofen pump. Well, this is a surgically implanted infusion system that's used to control spasticity. So its primary indication is to treat spasticity. And there are several components to the system that we'll talk about in a little bit more detail later on. But essentially, it has a battery-operated pump that's programmable and is attached to a catheter, and the tip of the catheter then lies inside the spinal canal to infuse medication directly around the spinal cord. And I can't really talk about baclofen pumps without talking somewhat about spasticity in general and why we're trying to manage that. And I think this quotation from an individual who suffers from spasticity is really solidifies why this is a therapeutic challenge for most clinicians. And you can go ahead and read that, but the end of it I think is really what is most revealing. Spasticity within friend or foe, I'll keep your goodness, the rest gotta go. So that tells us a lot about spasticity. Well, there are a lot of technical definitions for spasticity, but I think as far as what is clinically applicable to us, this is increased muscle tone and activity as a result of an injury to the brain or the spinal cord, which in combination is called the upper motor neuron. So you may have heard that term before. There are a wide range of symptoms that manifest as a result of spasticity, and these range from desirable to undesirable effects from spasticity, so positive and negative effects. It may manifest as muscle tightness or resistance to movement, involuntary jerking or muscle spasms, hyperactive reflexes, or limbs moving into certain patterns of movement involuntarily, or having some difficulty relaxing or coordinating or controlling movement the way that you would like to. It may occur at rest or actually in response to various stimuli such as stretching, very commonly, changing positions, or even just a touch. The reason spasticity is such an enigma is because it really has a very variable character, meaning that there are different triggers for different individuals and the presentation can be different for different individuals. So this can, for instance, fluctuate from one time of the day to the other, or spasticity or tone might be very different in quality when one is sitting versus standing and using their muscles. So this was brought home to my residents in clinic just this week. We had an individual who suffers from spasticity that was much better controlled with medications, or at least it seemed to be that way from examining them and sitting. But when we got this individual up to get them walking, it became very clear that their spasticity kicked in, and walking created a much different presentation of their spasticity. Ultimately, I think spasticity is both an objective and a subjective experience. That I can see, for instance, 2 individuals who, by my examination, seem to have the same amount of spasticity, but are affected by it subjectively in very different ways. So one person might be very distressed at what seems like very minimal spasticity to me, whereas another individual actually seems to be quite okay with that and even higher amounts of spasticity. So ultimately, when do we treat spasticity? What is sort of the trigger to start medications or even consider a baclofen pump? Well, I usually ask the question, as do most clinicians, is it causing more harm than good? Are there more detrimental or beneficial side effects to this? And will reduction in this spasticity ultimately lead to meaningful functional improvement for the individual? Examples of this might be if the spasticity is significantly interfering with voluntary movement, or if it's causing difficulty maintaining range of motion or a safe position in the wheelchair, contributing to pain or skin breakdown, particularly individuals who have a lot of flexor spasticity at night that sort of is triggered repeatedly. They can actually develop heel breakdown from the leg moving back and forth at night. And it ultimately can make personal care very difficult for those who require caregiver help. In spinal cord injury in particular, we see spasticity quite commonly after most types of spinal cord injury, and up to 49% or more actually require treatment of some kind. So what options exist regarding spasticity? Well, most of you in the room have probably experienced one or more of these forms. The non-pharmacologic or non-medication forms of managing spasticity include stretching or range of motion, weight bearing, splints or braces, taping, physical and occupational therapy, use of electrical or vibratory stimulation to the opposing muscle to attempt to relax the spastic muscle, using modalities such as heat or ice in different forms of cooling, massage, inhibitory casting, aquatic therapy, and the list kind of goes on and on. The advantage to these non-pharmacologic measures is that they're fairly innocuous. There are minimal side effects to using these interventions with a proper kind of oversight. The disadvantage potentially is we don't really know how effective they are as the sole form of treatment. For some individuals it works really well. For a lot of individuals that alone may not be enough to control the spasms in the way that they need it to be. And so the duration of the effect of these interventions may also be in question. We also have many pharmacologic strategies for managing spasticity. If spasticity that's bothersome is more a local effect or a focal effect, then we can use injection therapy using anesthetics or alcohol or phenol, or neurotoxins such as botulinum toxin injected, as shown, into the area with a spastic muscle. But more commonly, particularly for individuals who have spinal cord injury, the problem with spasticity is more diffuse and therefore it requires medications that have systemic activity. And these may include medications you're familiar with, such as baclofen, tizanidine, clonidine, benzodiazepines such as diazepam or clonazepam, gabapentin, dantrolene, and other medications. And there are also intrathecal medications that are used, and we'll be spending most of our time talking about that. The advantage is that they're generally very effective. We use that probably most commonly in the treatment of spasticity. The effects are reversible when the oral medication wears off. They can be used in conjunction with other medications and with non-pharmacologic management strategies for spasticity. The disadvantage is that they are systemically, they pass through a system to really metabolize the drug, and as such, to really get the most beneficial effect from these medications, sometimes you're experiencing the not so great side effects, the more detrimental side effects that limit the efficacy profile of the drug. And so most commonly for individuals with many of these medications, that might be fatigue or feeling very sleepy as a result of some of the medications that are used. Because most of these medications have a temporary effect, and the drug is only as good as the drug's half-life, essentially. So many times these medications are needing to be dosed more than once a day. So for some individuals who really don't like to have to remember taking medications 3 or 4 times a day, this can be a bit of a hassle in terms of the management. Some medications may have potential side effects on liver function or blood counts, and so they may require some periodic monitoring of lab work as well. There are surgical management options for spasticity. They're rarely used nowadays, but they do exist. We need to talk about intrathecal pumps as one of those surgical strategies, and there are ablative or destructive surgeries that lesion parts of the spinal cord or the nerves coming from them in an attempt to control the spasticity reflex. In terms of considering which the best option is for you, there are many, many considerations, including what your goals are for treatment of the spasticity, what the distribution of the spasticity is in your body, how reversible you want the treatment strategy to be, the potential side effect profile, the efficacy of the intervention, and what other health conditions might affect what the most efficacious treatment strategy would be for you. We'll talk about baclofen a little bit in particular, since that's really the thrust of the talk today. So baclofen is a drug that relaxes muscle by inhibiting the reflex action that's generated in the spinal cord. And there probably are some receptors in the brain as well, which is why you have some of the sedation effects from baclofen. The antispasticity effect of baclofen probably comes from characteristics that make it structurally similar to a naturally occurring chemical neurotransmitter in our body called GABA. And GABA is well known to have an inhibitory effect on the nerve's ability to trigger muscle and therefore trigger reflexes. Oral baclofen has certain pharmacokinetic properties that make it ideal to use about several times a day, 3 or 4 times a day for most people, because its half-life is about 3 or 4 hours. So this is the amount of time it takes for your body to get rid of half of the drug in your system. And a 60 milligram single oral dose of baclofen, which is 60,000 micrograms, just translated, would result after it's systemically metabolized in only 0.02 micrograms per milliliter concentration in the spinal fluid around the spinal cord. Whereas a 600 microgram per day intrathecal dose that's given through a catheter system and a pump would actually result in far higher concentrations of baclofen in the cerebrospinal fluid or spinal fluid. So you can see there's quite a bit of difference and a potential advantage to administering this directly in the spinal fluid. So baclofen pumps have been around for quite some time. They actually originally were developed to deliver pain medications in the late 1980s, and in 1992 the pump was approved by the FDA to deliver baclofen to manage spasticity because of spinal cord injuries, and then in 1996 for spasticity due to cerebral or brain disease or injury. So it's been around for some time. And the idea behind it is it delivers a very precise dose of liquid baclofen into the intrathecal space. So what is the intrathecal space? I get asked that question a lot. And really this is the space inside the spinal canal and in the fluid around the spinal cord. So it's not in the cord itself, but in the fluid that bathes the cord and inside the bony canal. So the key concepts to intrathecal baclofen is that it's a direct infusion into this intrathecal space. And because it's a direct infusion, it then minimizes the drug dose that's needed to be effective. And so this therefore may be able to limit or eliminate the common systemic side effects associated with the oral dosing of the medication. Because it's precise and consistent drug delivery throughout the day, then you avoid the peaks and valleys of the effect of oral medications that are dosed several times a day. And because it's a programmable system with a lot of flexibility built into it, you can have your choice of several different infusion programs. So you can have the same dose administered on an hourly basis 24 hours a day, or you can choose to have what's called a flex mode, and this allows you to set a different rate in the morning versus the evening time if you need more or less spasticity during different times of the day. And you can even set different days of the week if you have a different schedule during the week than for the weekend. You can also schedule a periodic bolus. So for individuals who seem to get the most relief of their spasticity from larger doses of the medication all at once, sort of simulating what you get with oral medications, we can give you a large bolus scheduled every few hours if necessary. So it has a lot of flexibility that way. So there are certain system components we should talk about. First is really the pump itself, which is really a metal canister. And I'll just kind of walk over here and show you. So these are samples of the pump here, and we'll pass this around so people can get a feel for the weight of these and the size of these. So this is a 20 milliliter pump. This is a 40 milliliter pump, and you can see they're not terribly different actually in the actual size, and even its profile is not significantly different. That's a new development in the pump. So this pump is a metal canister that contains a battery and a programmable component that stores information. So there's a lot of information we can put in these pumps nowadays. And it has a drug reservoir, which then the entire pump is surgically implanted under the skin of the belly on either the right or the left side. And one of our panelists actually is willing to show us what that looks like in his abdomen today. And then this is connected to a catheter system, which this one has that attached. You can see this catheter system is threaded underneath the skin around the torso and goes into the spinal canal and is threaded up to a predetermined level depending on how much spasticity you have in your arms, your trunk, and your legs. So the tip location is adjustable only at the time of the implant. So I'll pass this around so people can get a feel. So the third component is the programmer, which when I first learned about these came in a big suitcase. In a big system that you really couldn't carry by hand. And I think as with all technology, it's morphed into something that's handheld and smaller, so I'm waiting for the next generation of these to come through. But we use this system, and it's got a telemetry head, so it uses radio telemetry to actually read the pump information, or what we call interrogation of the pump, or analysis of the pump, and then to reprogram the pump to tell it what we want it to do. Okay. So the details. Medication is instilled into the reservoir, which lives inside of the pump, and there's some inert gas, a desiccant, that's inside the pump that then puts pressure on the reservoir to push medication through some internal tubing. There's a battery-powered microprocessor inside of this pump that controls the flow rate by operating the rotor, which then drives the medication through the tubing into the actual catheter outside of the pump. Okay. The medication then flows through the catheter into the spinal fluid fairly slowly. So this is kind of what it looks like in general. You can see the rotor head here, the pump head, which has internal tubing. The actual reservoir is below that, and I think probably the most relevant aspect for you to know is that when we try and refill pumps, we're actually trying to hit this refill septum, which is right in the middle of the pump. You can see how small that target is relative to the size of the pump. The sample pumps that are being passed around, I think they don't have a septum. One of them does. And so you can get a sense for why it's really important that we align this template that we use for refills the correct way to be able to access that. So how does it work? I'm not a great fan of this diagram, to be honest, because it's not even really to scale. But you can see that the catheter goes through between the vertebral bodies, which is what those yellow boxes are supposed to be if you're looking at someone from their side. And the catheter, actually in this case, is probably not correctly placed, but it should be in this space right here, which is the fluid around the spinal cord. And then it's absorbed into the spinal cord itself through capillary flow. So what does it take to maintain a pump? Because we have different phases, and I think people tend to worry the most about the actual implantation. And really what I want them to worry about beyond the implantation is what it's going to take to maintain this pump. And so let's talk about what it requires. So first of all, the most important thing are the refills. And really what it boils down to is the frequency of the refills will depend on which drug concentration is used and the daily dose that's required and the pump size. So it's equivalent to sort of gas in your car. You can only have so much in the system. It needs to be refilled periodically, and how much it needs to be refilled just depends on your use. So there are two commercially available preparations. There's a 500 and 2,000 microgram per milliliter concentration, and we've made a conscious decision here with our program not to use compounded baclofen preparations, which are used in the community because of some literature that suggests that there's a little less predictability with what you're actually getting, and that there can be 5% or more variation in the actual dose concentration when they actually tested compounded drugs from different pharmacies. And so we've made a conscious decision and effort here to only use these commercially available preparations. There are two pump sizes that, as I mentioned earlier, a 20 and a 40 ml. And we encourage people generally, unless there really are size issues or cosmetic issues, to try and consider the 40, only because then you're not being refilled as frequently. There is an older model of a pump that we're really no longer implanting, but there are people who may have this pump that only has an 18 milliliter capacity. At minimum, because of FDA regulations for how long the drug can remain in the system, you have to be refilled every 6 months, even though you're not empty. So every 6 months at minimum is the amount of the refill. And people will vary between every 1 to 6 months depending on the dose and concentration. So the refill does require an injection through the skin to access the pump. And the general procedure is that we interrogate or analyze the pump, and we try and confirm how much we expect to be able to withdraw as residual amounts in the pump at that specific date. We then access the pump with a needle, and we withdraw the remaining medication, and we see if that matches what we expect to get back based on what the programmer tells us we should expect. We then infuse the new drug, reprogram the pump, and the most important part is to not forget to schedule follow-up. So this is actually a set of pictures that I took just last week with an individual who has a very visible pump. So most pumps are not usually this visible. So this is sort of a good example of a pump refill because it's photos because it's very, very obvious what we're doing here. So the pump looks like that in the system, and you'll see other people have it a little bit less evident. And there are other techniques to try and bury that a little bit deeper or at least have less potential for skin breakdown over the pump if necessary. So the second picture shows you that we talk to the pump just to interrogate and see how much we expect. We then drop the medication, which is what that big syringe is. We then clean off the area, sterilize the area with betadine. And then we align a template over the pump. And this template I'll show you here looks like this. And so we lay this over the pump in a particular orientation, and we need to really try and hit the right target right in the middle. That helps us find the reservoir septum. We then withdraw the medication, switch syringes, infuse the new medication, and then we reprogram the pump to tell it that we've refilled it. Other maintenance requirements when you might need to see us for pump analysis or reprogramming. If there's been any trauma to the pump site where you're concerned about whether the pump is working or not, we would then bring you in to just analyze the pump or interrogate the pump. Any MRI exposure will temporarily actually stall the rotor system because it's a magnetic force, and it in the large majority of cases will restart itself within about 2 hours or so. So we usually like to see people about within 2 hours of when they had an MRI to just confirm that the rotor has restarted itself, because otherwise it may actually remain in a stalled state, and that's not a good thing. With any activation of alarm system, so these pumps have an alarm system that will tell you when there's a problem, or it perceives that there's a problem based on what's programmed into the pump information. So the important thing to know is that this doesn't always sense when there's a problem. So it tells you that the pump's low on fluid or empty based on what the programmer tells it should have at any one time. So it doesn't sense anything. So if you hear any alarm activation or you suspect there's a malfunction of the pump system, then we would want to see you to be able to interrogate the pump. We would definitely be seeing an individual for pump reprogramming to adjust the dose to get it to the ideal infusion pattern and dose. And because this is a battery-run device, implanted device, there is a finite battery life span, and so at end of life, in about 5 to 7 years, we would then be looking at getting your pump replaced by the implanter, ideally on an elective basis and not an emergent basis. The potential direct benefits to intrathecal baclofen therapy are reduction in muscle spasms and that high resistance to passive muscle movement, to improve function and independence so that you can participate in activities of daily living, to reduce caregiving need, and to reduce pain that's related to spasticity. When should intrathecal baclofen therapy be considered in the management options? When there are unacceptable side effects to the effective doses or dose combinations of systemically administered medications. So when you're too fatigued or too lethargic with oral baclofen, for instance, this is a time to maybe consider this option. Or you might have insufficient spasticity control using your other options. So you're doing a combination of stretching, you're being really adherent to what all of your rehab doctors are recommending. You're standing, you're stretching, you're getting a lot of range of motion, you're wearing the braces, you're taking 3 or 4 different oral medications in that combination isn't quite enough to really control the spasticity in the way that you want it to, then it's time to consider this option as well. If one desires a reversible option and is willing to consider surgical treatment, then this is a time to reconsider this option as well. If you are concerned about a more precise dosing or more consistent dose effect throughout the day to avoid the peaks and valleys of the oral medications, or if a flexible dose regimen is important to you, this is probably one of the most precise ways that we can actually create a flexible dose regimen where we know what's getting into your system. So something important to note is that just because you don't respond to oral baclofen doesn't mean you're not going to respond to intrathecal baclofen. I think that's a common misconception. And so it shouldn't eliminate the possibility or eliminate this as a consideration just because you've tried oral baclofen and it hasn't worked for you. So the conditions that are associated with spasticity that can be aided by a baclofen pump include spinal cord injury, brain injury, both traumatic and non-traumatic injuries, multiple sclerosis, and primary or amyotrophic lateral sclerosis. And really this intervention will treat individuals with a wide range of abilities, those who are walking, those who aren't walking. And we're going to see from our panelists today and hear from our panelists today from individuals who have a wide range of abilities. How effective is it in spinal cord injury? Well, a lot of the statistics we have are a little bit dated, but we know that when people went through the screening trial, which we'll talk about this process in a little bit, that 97% of individuals who had spinal cord injury and MS sort of as a group had significant responsiveness to this trial. So that tells us that generally it's very effective at reducing spasticity in the spinal cord injured population. With Ashworth scores, an Ashworth scoring system is probably the best measure that we have to try and assess someone's spasticity, although it has its limitations. On average, at least on this older Ashworth scale of 0 to 5, the average reduction was about 2.8 or 3, so that's a significant amount of spasticity reduction. And then they found potential additional benefits that were not really the primary intention of treating this with intrathecal baclofen therapy. So some people noticed that they had decrease in pain, decrease in bladder hyperactivity, or decrease in the amount of time that's required for caregiving. So those shouldn't be the primary reasons people are having pumps implanted, but there might be some side benefits. So to present a very balanced point of view about baclofen pumps, we really need to talk about the disadvantages, considerations, and complications from this therapy as well. First of all, in my opinion, there's a finite battery life. So these systems need replacement about every 5 to 7 years. Generally, if the catheter is working well, when the implanters go in, they really just change the pump and not the catheter system. They reattach the existing catheter system. So it's not as major of a surgery the next go around as it was the first time. This does require periodic injections to refill the pump reservoir. So if you're kind of needle phobic, this is a consideration. There are potential surgical complications with any surgery. We worry about bleeding, any infection of the surgical sites, and particularly since this is an implanted device, this has a potential to get infected as well. We worry about surgical fluid formation around the pump or the surgical sites following the surgery, and the usual anesthetic risks that are associated with any surgical procedure. It's an expensive procedure, although there have been arguments that for a certain population of patients this is ultimately cost savings. This is still an expensive procedure relative to medications on a daily basis. There are potential complications related to the pump or catheter system, and more importantly from human programming errors that clinicians may make inadvertently. Intrathecal baclofen, because of its certain characteristics, is really best used for treating lower leg spasticity or lower limb spasticity rather than upper limb spasticity. The tip of the catheter can be targeted to be higher in the spinal canal to try and affect arms and trunk spasticity, but in my opinion that shouldn't be the primary reason you're putting a pump in, is to control upper limb spasticity. It can be attempted, but this is really best used for lower limb spasticity. And finally, there are some individuals who use their spasticity in a meaningful fashion to help with standing transfers, help with walking, and sometimes it's really hard to distinguish when we assess people up front how much of it is strength, how much of it is spasticity that you're using, And so taking some of that tone away may actually then unmask some underlying or latent weakness and therefore have some unexpected negative impact on functional ability. And there's really no great way of predicting this in advance. There are definite contraindications to baclofen pump implantations, such as hypersensitivity or allergy to any of the products that are contained in the preparation, any active infection that potentially may get the surgical site or the implanted device infected, and really anything that makes it technically difficult to either place the pump and catheter system or to refill the pump are contraindications. So there are several different phases to considering baclofen pump implantation. The first is patient selection, followed by the screening process, followed by the implantation, and then I think more importantly the maintenance and long-term follow-up and rehabilitation. The patient selection process is, in my opinion, one of the most critical aspects to making a pump program successful for all of the folks participating, because it involves a lot of education, as you're receiving today, about the advantages and disadvantages of the pump and what's required to maintain the pump. This is a period of time where we're trying to elicit what an individual's goals are, but also their caregiver's goals if they're requiring caregiver help, or their therapist's goals if their therapist is working with them. And then the provider really needs to determine if this is potentially something, or whether these goals can be achieved realistically with what we know this therapy can provide. In our system here, but also in other systems, they may have a multidisciplinary assessment by nurses and therapists in addition to the rehab provider as part of the assessment process. And I think this actually offers a great deal of additional perspective to the selection process. So I can sit there and move someone's legs around either on an exam table or in the chair, but it's just as meaningful to me, if not more so, to watch these individuals transfer, move from a seated to a laying position, turn from side to side, or stand up and walk and operate their power chair or manual chair. Other considerations that go through my head when I see someone who might be considering pump therapy is I'd like to know a little bit about how reliable they are with following up with medical recommendations and appointments, and whether they seem to really understand the potential risks and benefits of this treatment. Do they have a stable living situation so that I know that they can get access to an appropriate medical center that's knowledgeable in pump therapy if there were an emergency? And really, if there are realistic goals that can be achieved. The number one source of dissatisfaction with this therapy potentially is a mismatch in what the individual feels the goal should be and what this therapy can realistically provide. And we're trying to make sure that those goals are aligned from the very beginning. So what goes on in the screening trial? Well, the screening trial is really meant to determine if the spasticity that an individual has will respond to intrathecally administered baclofen. It's purely intended as a physiologic test of candidacy. And during this trial, there's a single bolus injection of 50 micrograms that is injected via a spinal tap into the lumbar spine, into the intrathecal space. And most commonly, whether it's here in the community, they're performed by a variety of different providers. And at University of Washington, they're performed by our pain physicians with the anesthesia department. But in the community, they may actually be performed by a rehab provider or a neurosurgeon, radiologists. It might be other providers who are actually doing the injection. Ideally, there's a 4 to 6 hour observation stay with monitoring for potential side effects and really monitoring for what we hope to see, which is spasticity or tone reduction. And ideally, one is getting a functional assessment during that period of time rather than the injector really just moving your legs around or your arms around. There's some level of an attempt to do a functional assessment for how your spasticity is impacted in that way. And at least at the University of Washington, we do have therapists, both PT and OT, who actually come and work with patients prior to the injection and between 2 and 4 hours post-injection. So what is a good result? So a positive result is really the achieving the desired response of reduction in spasticity measures and achieving some sense of either the lower limbs becoming completely flaccid or loose or relative tone reduction. A negative response is really having no or insufficient reduction in spasticity to the bolus injection. If the trial was deemed to be negative at 50 micrograms, you have 2 more opportunities to actually demonstrate that this is a good therapy for you. You can try it at 75 micrograms, or some people just go directly to 100 micrograms. They have to be done on different days. They can't be done on the same day. If one responds to any of these bolus doses, then you're considered a responder and appropriate, at least from a physiologic standpoint, to have intrathecal baclofen therapy. If you don't respond at 100 micrograms, the thought is that this is probably not the best option for you. So as with any medication treatment, the drug effects can vary from individual to individual. So during the screening process, how one person reacts to the screening process and their reduction in spasticity may be very different. So the onset typically is about 1/2 to 1 hour after the injection. You're starting to feel the effects, but the peak may not be until 4 hours later. Oftentimes you're starting to see that sooner, but it can be 4 hours later, and the effect can actually last 4 to 8 hours or even longer in some individuals. As I mentioned, usually during this period of time you're being monitored for the effect on your muscle tone, but we also monitor for things that we worry about which are fairly uncommon, but drop in blood pressure, drop in your respiratory rate, urinary retention, or GI side effects during this time. So it's really important to be in an environment where you're sufficiently monitored during this trial. The hint that I give people that's helpful is to prepare for the possibility that you have such dramatic reduction in tone during the trial that by the time that you go home, you may not have all your usual tone back. So in cases where someone needs to be able to perform a standing transfer, you might need to be prepared to do a sliding board transfer or an assisted transfer from a caregiver. Or if you're up and walking and you use your spasticity to go upstairs, it may not be a great idea to plan on being able to do that at the end of the trial. And again, we don't have a way of predicting the response in advance. The screening trial is helpful because it will help us differentiate how much of the reduction in movement is due to weakness versus spasticity versus fixed contracture. Because if it's fixed contracture, there's not a whole lot that intrathecal baclofen is going to help you with, and because the soft tissue is then already foreshortened. It's important to know that during the trial process, the dose cannot be adjusted. It's sort of just one dose. It's intended as a one-time screen for responsiveness to the baclofen delivered through the spinal fluid. And the dose may result in extreme flaccidity or muscle tone loss or less than ideal tone reduction during the trial period. But this doesn't mean that this is the same response that you're going to get when the pump is actually implanted. So the pump dose can actually be adjusted to provide more or less tone reduction than is actually experienced during the trial. So I have to say that I am not an implanter of these pumps. These pumps are placed usually by our anesthesia department or the neurosurgeons, and so I'm describing this sort of a secondhand information on the technical aspects of the implant. But generally, there's a process for selecting the optimal site for the pump implant, and it typically goes in the lower abdomen on either the right or the left side, so you'll kind of be a righty or a lefty. And there's a little bit of negotiating that happens as to how high or low in the abdomen the pump is actually implanted. And considerations for individuals with spinal cord injury is if you have a zone of transitional sensation where it goes from normal to not too normal, there can be an area that's very, very sensitive to touch. And so this is not the area where you want us going through to refill your pump. So you might negotiate then with the implanter to place this outside of an area that's painful for you. It's also important to think about clothing. So this frequently will have clothing, belt lines, and your pant closures overlying this area potentially. So you want to make sure that when you're sitting up or laying down, and they'll actually move you around in different positions, that the pump is where you want it to be. If there are any ostomies, colostomies, or urostomies, that's a consideration for where the pump is placed as well. Or your seated posture. If you're someone who tends to be sort of in a flexed posture when you're seated, some people have complained that the pump is sometimes placed a little too high, that when they're seated, it rubs against the bottom of their rib cage. So that's a consideration as well for putting it a little bit lower. So typically when they're placing the pump and the catheter system, they start with the catheter and insert this into the spine, and it's inserted low in the back, goes through the bones of the spinal canal, and then it is threaded into the intrathecal space and up. And how high up it is depends again on what regions of the body we're trying to target. And then the implanter will then go to creating an abdominal incision for the pump itself, and the catheter is threaded around underneath the skin, connected to the pump, and the whole system is then internalized. And then the initial dose actually programmed. So many of these pumps are already active at the time that you leave the operating table. So what about dosing of intrathecal baclofen? There's a lot of technical information that's actually programmed into the pump at the time of implant, in addition to the pump infusion actually starting in the majority of cases. The starting dose is actually determined by your providers, and this dose may actually be adjusted within the first 24 hours or more. The only caution I would have with too frequent of a dose adjustment, because it really can be done almost every day, is that you need a period of accommodation in terms of what your functional skills are to the new dose. And if you're rapidly changing that, your body's trying to get caught up with what the functional abilities are as they change. And so, you know, I would leave a little period of time where you need a little bit more accommodation. So most people don't know that it sometimes takes up to several months for many people to achieve the right dose amount, what's considered to be the ideal dose infusion and the ideal mode of infusion. And what I would consider an ideal dose is one that balances the amount of spasticity reduction and achieves the functional goals that you have stated at the outset. It's also important that if you have a baclofen pump implanted, that you make sure that your oral medications are continued even after the pump is implanted for a period of time. There are very potentially severe reactions to suddenly stopping your antispasticity medications. They actually need to be gradually weaned as the pump dose is increased gradually. There is finally a large range of final effective doses for you. So what works for your friend who has the same level of injury and spasticity may be very different than what you may require. And even though in general we tend to think of the amount needed according to diagnosis, there's really not necessarily any rule. And you can see dose ranges of 25 to 1,400 micrograms a day. It's really what works for you. And it's completely unrelated to the size of your body. So this is the potential bad stuff that can happen. So we need to talk about the potential complications. And even though they're really quite infrequent, we need to discuss this up front so that you know what the therapy is good for and what the potential complications are. What we worry about in the acute post-implant period is any swelling that develops around the pocket or catheter site that might indicate that there's fluid formation, something called a seroma, or infection. And so we watch for that fairly closely after the pump is implanted. People can develop wound problems either with the surgical incision themselves, or I've seen some fairly nasty reactions to even the tape that they use to put on the dressing that goes over the pump incision. Individuals, because this is essentially using a spinal tap type of process, can develop a spinal headache after the pump is implanted. And there can be baclofen overdose or underdose symptoms while the medications are being adjusted, both your oral medications and your intrathecal medications. Over time, we worry about problems that are related to directly to the pump or catheter, but you should also know that on rare occasions the pump can actually flip upon itself. Theoretically it should, and it's anchored down, but in some individuals, depending on your body type, it might be a little bit more mobile, so they can actually flip around, and then we'll know because we're having trouble accessing that septum to refill your pump. So on the Medtronic website, Medtronic is at this time one of the providers of intrathecal baclofen therapy through this programmable system that we've passed around. They actually have a voluntary registry, and they actually monitor the performance of their pumps and catheters as well as other system complications that are unrelated to the device. So you can see probably from this report that the most common pump-related event is a motor stall. Still relatively infrequent if you look at the total numbers of 1,506 events reported, numbers of 21 having a motor stall. Fairly rare and infrequent. And there are catheter-related events which are a little more common than pump-related problems, where there can be a cut or a small break in the catheter that develops, or a disconnection of the system, or a dislodgement of the catheter, or the catheter actually kinking and occluding upon itself. Again, the numbers are relatively low, but you need to be aware that that is a potential complication. There are other factors that lead to complications. Not an insignificant one is human error. The pump is only as good as the people who are managing your pump. So the highest probability of human error is within 48 hours after anyone has touched that pump to refill it or reprogram it. And so the errors that can happen are we program numbers incorrectly if a clinician infuses the drug into the pump pocket rather than into the pump itself, or if the wrong drug concentration or amount is used. So again, it's only as good as who's managing your pump. If you already have a baclofen pump in, you need to be aware of what signs and symptoms are that are of concern that would indicate that you need to see your pump manager as soon as possible. And this includes signs of baclofen withdrawal and overdose. Baclofen withdrawal is far more common an event than overdose, and so symptoms of baclofen withdrawal are typically sudden increase or resurgence of your spasticity or your tone, profuse sweating, and itching without an associated rash. You can also have fever, and sometimes people get worked up unnecessarily for bladder infections and bloodborne infections when really all it was is your pump was running low or your pump had run dry. You can have a high heart rate or high respiratory rate or high or low blood pressure or even confusion. The danger area is when you get into more severe symptoms of baclofen withdrawal, which would include hallucinations or delirium, seizures, rhabdomyolysis, which is where you actually start to break down muscle, and this can lead to various organ failure and even death. So you can see immediately, even though this is extremely rare, why we need to make sure that you understand the reasons why we're being very selective about who is appropriate or not appropriate to get the pump. There are many people whose spasticity we can really improve with intrathecal therapy, but not everyone should go through this process. The key concept I want you to go home with is that if you have a baclofen pump and you're beginning to experience mild symptoms of withdrawal, you really shouldn't wait to contact your provider. Because in many cases where people went into severe withdrawal, when you look back at those cases, they really started with mild symptoms that progressed. And so in most of these cases, we lost an opportunity to recognize and treat the symptoms early on. So you need to know the signs and symptoms and contact your pump provider as soon as you suspect withdrawal. So having said that, it's very difficult sometimes to determine when the pump is really the source of the problem. And when you have an implanted device, I think there's a real tendency to always blame the device because it's what you worry about the most, right? But really there's so many other conditions that can occur that are completely unrelated to the pump that can produce symptoms that actually mimic baclofen withdrawal. So urinary tract infections, urinary stones. We had a woman who had a hip fracture who actually thought that she was having problems with her pump when it turns out that she had fallen and actually had broken her hip. It can be anything that creates an increase in spasticity, and it's good to think about the pump first, but people should think broadly about other health issues that might be contributing to the increase in spasticity. Other mechanisms of withdrawal is if the pump actually runs empty, or if there's a programming error from the pump provider, inaccurate baclofen concentration, or a problem with the catheter system, or a problem with the battery. Usually with most of these you're getting some kind of alarm activation, so you might be hearing an alarm triggered. The treatment is really to resume baclofen infusion or oral medication as a substitute as soon as possible. So the treatment for baclofen withdrawal is really baclofen. In cases where you're in the emergency room and you really just need something urgently, they can use IV diazepam as an option, and it's a good option because ER doctors are usually pretty comfortable administering that. So my hints for preventing baclofen withdrawal is probably first and foremost is to keep an adequately planned for all refill appointments. So whatever system you like, your smartphone, your BlackBerry, your iPhone, your calendar, you need to make sure that you're following your appointment schedule or planning for it. If you have a big long travel across the pass and it's the winter, you might want to schedule your refill a little sooner than a few days before the pump's supposed to run empty. You need to know how to recognize and differentiate the pump alarms. If the alarms have not been demonstrated for you, there's a way that we can use our programmer to show you what those alarms sound like and what they mean, because there are two different types of alarms. You need to contact your pump manager or provider as soon as you notice an alarm, any withdrawal symptoms, or suspect a system problem of any type. And make sure that we see you or your provider sees you after you have an MRI to ensure that the motor stall has actually recovered itself. And keep a supply of oral baclofen or other anti-spasticity medication with you at all times in the event that you have a withdrawal reaction. If you're traveling, you should always have oral medications with you. So we can talk about overdose, again, far less common, and there's a wide spectrum of overdose symptoms ranging from just getting a little too loose to really having respiratory depression or significant amounts of sedation, even respiratory depression that actually requires mechanical ventilation or intubation for a period of time, and ultimately, hopefully not, death. So possible causes, again, are human error, inadvertently filling the wrong area of the pump, or programming the pump incorrectly, or refilling it with the incorrect concentration of drug, or if there's any catheter or pump malfunction, or not uncommonly, actually, in some population of individuals, they confuse the combination of the intrathecal and the oral medications. They end up taking a little too much oral medication or confusing the directions on how to wean oral medications, and so that can result in overdose symptoms. Most of the time, this can be very easily managed with just turning the pump rate of infusion down. In some cases, we actually have to stop the pump infusion and then administer some advanced respiratory support or an antidote to the effects of the baclofen overdose. But the vast majority of the time, we're not getting to this level, and hopefully, if we prepared you enough, you're not getting to that level either by the time you present. So there are certain absolute restrictions with regard to the pump system. If you're an avid scuba diver, this is not the system for you. Anything that changes the pump's, the pressure or temperature in and around the pump would not be a good thing. So heat, such as ultrasound directly over the pump site, hyperbaric oxygen chambers, skydiving, things that potentially will cause a lot of trauma to the pump system are contraindications. After the implant, we can talk a little bit about the rehabilitation care, because this is, of course, my favorite topic. So there's been a little bit of controversy about how aggressive you can be with activity and rehabilitation after a pump is implanted. And I think for a long time, there was this movement to keep you at rest because we want to make sure that there's no dislodgement of the catheter from the pump. And we want to make sure that everything scars down, so we don't want you moving around a whole lot. We're doing a lot of rehab. And I think we've really moved away from that philosophy, and we actually here will even admit some people in inpatient rehab sometimes directly within, maybe a day or two after the pump's implanted to do some aggressive therapy with you. Having said that, there are certain restrictions with regard to activity that we usually advise the team of therapists about, which is to avoid any rapid or forceful bending or twisting movements. And there are certain aspects of the care that might cause excessive pressure on the pump, such as the mechanism of transfer. We might look at that a little bit more carefully at the time that you're doing rehabilitation. Usually the surgeons have given us some advice about the skin care for the pump, for the surgical site, and they also usually don't want anyone laying on the pump, so doing the prone lay. If you're someone who likes to lay in your stomach, there would be a contraindication for doing that. Oftentimes after the pump implant, you may be advised to use an abdominal binder to just keep pressure over the pump site, keep the surgical site together, but also to keep down any seroma or extra postoperative fluid collection over that pump. So after the implant, this is really where you want your rehab provider to be reassessing you with new eyes. This is a time when we might be unmasking some latent motor control capabilities and resetting new treatment goals, readdressing your equipment needs if your positioning changes, your seating system, your orthotic needs, or even upgrading your home exercise program. Frequently, individuals who have intrathecal baclofen therapy will need either outpatient or some level of inpatient rehabilitation, depending on how much the function changes after the pump's implanted. And it may even be a time to reassess the amount of caregiving help that you're requiring after the pump is implanted. Things that I think every patient with a baclofen pump or their caregiver should know: you need to know the dose and concentration of the drug in the system, Usually there's a system of checks and balances when we're refilling the pump to avoid this, but it's very helpful if you know what that is in case you end up in the emergency room. You need to know the size of your pump and your next alarm date. So usually when the pump's been refilled, we will tell you when your low volume alarm will be going off. And so we are trying to set an appointment up usually the week prior to that alarm going off. So you need to know your alarm date. Know signs and symptoms of withdrawal and overdose from baclofen, what to do in the event you hear an alarm that's activated, and you need to know who to call if you have a pump problem. I really can't emphasize that enough. So my hints to getting the outcome that you desire from intrathecal baclofen therapy is, first of all, to know yourself and your spasticity, know what the triggers are, know what the patterns of spasticity are, what seems to help, and know what options you've tried in the past, because this will make the screening process much easier to perform. You need to have clearly stated goals for spasticity reduction. As I mentioned, we can most of the time make people's spasticity far less than what it is before intrathecal baclofen. However, that in and of itself shouldn't be your primary goal for having the pump implanted. There should really be a functional goal accompanying that. So is it to improve your function, increase your range of motion, make it easier to care for you, or eliminate or even reduce the number of medications or the medication frequency? And finally, you need to ask if these goals can be realistically achieved with this treatment with an acceptable risk profile for you. You need to know the potential risks we talked about, such as signs and symptoms of overdose and underdose, but you also need to know how this might potentially affect your function. People who rely on their spasticity to sit up at the edge of the bed, or to balance, or to do standing transfers, or even walking, you need to know up front that it might be more difficult. There might be a period of rehabilitation after that to try and regain what you may have lost in terms of muscle tone. And we don't always know, even with a rehabilitation, how much people will get back. You need to ask yourself, are you someone who's able to participate in the maintenance process and phase of this therapy? Are you able to access care in the reasonable amount of time in the event of an emergency? And are you or your caregiver able to provide surveillance for and recognize a potential emergency or alarm activation? You need to ask about factors related to the implanter. What is their experience in implanting and troubleshooting these systems? And because the device and the therapy is only as good as the pump manager, you need to ask about the management philosophy, style, and availability of the pump manager. I personally have always felt that rehab offers a significant advantage in managing baclofen pumps because part of our training to become rehab providers has to do with spasticity in general, not just the technical aspects of putting a pump in. It has to do with looking at all of the strategies that you're using to manage your tone and knowing a lot about the underlying process that produces spasticity in the first place. You want to know what their experience is with refills, management, and troubleshooting. And you want to know if they're using commercially available or compounded drug, because that may make a difference for you in terms of whether you want to get your care there. Or are they a strong believer in mixing drugs in a pump, which we don't do within our program, but other programs do, where there might be a little less flexibility with adjusting just one medication in the pump rather than both of the medications at the same time. You want to ask specifically, how are emergencies handled? Is it an academic program like this where you'll be contacting your resident first? Has that resident received adequate training in intrathecal baclofen therapy? And is there an attending physician who serves in a supervisory capacity who's experienced in baclofen pump therapy? How are records kept and maintained and handled? Do you have access to your records related to that pump therapy at all times in the event that you are in an emergency situation and you go into an emergency room that's not where your pump manager does not have privileges? You need to have access to that information in an emergency. And lastly, you need to know special considerations that might be specific to you and your physiology or your body. So if you have had prior extensive fusion of your back, that might make it difficult for the catheter to get threaded through the system. That might be a strong consideration about whether this infusion treatment is the right treatment for your spasticity, or if there are pregnancy considerations for the future that need to be discussed in advance. If you're chronically anticoagulated with Coumadin or other blood thinners, that might pose a little bit of a risk during the implantation process, that there needs to be a discussion about the potential risks and benefits of holding that drug or changing that drug for some time. or you might have questions related to how compatible this is with other implanted devices if you actually have an implanted device. To summarize, really, intrathecal baclofen is an option that can unmask a lot of rehab potential. And like any treatment option that's out there, intrathecal baclofen therapy is associated with possible complications. So you need to ask yourself, what are my goals other than just spasticity reduction? And can they be realistically achieved with this intervention with a risk profile that is acceptable to me? You need to know what to expect, what you hope to gain, and work with a knowledgeable team with a compatible philosophy to get the outcome that you desire. So I think at this point I'd like to invite our panelists to actually come up front, and then we will pose several questions for them, and then we'll open it up to some questions and answers. So what I'll do maybe is have everyone introduce themselves and tell us the underlying diagnosis, that if you're comfortable with that created the spasticity that required the pump.
Hi, my name is Aditya, and I'm a C5 level quadriplegic. The underlying diagnosis was a lot of spasticity that occurred pretty soon after I got discharged from the hospital, and basically that was it. I tried a lot of different oral medications, and this was the last effort at it.
I got it.
Oops, we can't let go. Got it?
Billy Price, I'm a C6 quad, and I got my baclofen pump when I was actually still an inpatient at the hospital. At the time, this is about 13 years ago, at the time I was in the hospital for about 5.5 months. And during that rehab, it was brutal. I mean, I really couldn't go through rehab because my body just wasn't really cooperating. And it's one thing not being able to move your body, but when your body's moving when you don't want it to, it's just hell. So at the time, the baclofen pump was somewhat new, I guess, and I got it, and it really just changed my life. I was able to, be able to move on with my life, so it was good.
My name is Allison Rainey, and I have multiple sclerosis. And I actually did the oral baclofen, but then I had the side effects. The dose was high. I couldn't go any higher in the dose, but I wasn't receiving the benefit of the drug because it was no longer helping with my spasticity. So that's when we decided to do the pump trial, and the difference is amazing with such a low dose of how much. And in fact, like I always say, I walked into the hospital, but I came out in a wheelchair just because it made me so much more flaccid than when I came into the hospital. But now it's starting to balance out, so I am still able to use some of the spasticity for transfers.
So Allison has a really unique perspective that way, and the reason we wanted her to be on the panel is she is partially walking, and so she has a very unique perspective for baclofen therapy and how it affected her ability to do some standing activities, and how she was able to work with her therapist, Marie.
So I'm Marie, and I'm Allison's physical therapist, as well as quite a few other individuals with baclofen pumps, and kind of participating in the determining, first of all, the trial process of who might be a good candidate, but second of all, in the long-term outpatient realm, about what's the appropriate dose for balancing tone and function, and tone reduction, but being able to function at the level you want to function at. So that's the role I play.
So the first question maybe for the panel is, and I think some of you spoke to this, why you decided to get the baclofen pump, and what advantages or disadvantages or side effects have you seen since the pump was implanted?
The only really negative side effect is that I did get the lovely spinal headache, and lasted about 7-8 days. So in the hospital, that limited amount of rehab that I could do, because every time I sat up, I had an awful headache. The positive is that I have more control, and that was really what I wanted. Even though I am in a wheelchair now, I have control, so I'm falling so much less than, like I haven't fallen in like the last month or two, and that's really good because I was falling on an almost daily basis, so it's definitely helped that.
I had the spinal headache too, and it is brutal. I was out of commission for about 3 days. Other than that, there really haven't been any complications.
I didn't have the spinal headache, but I did have some other fun complications. I was really thin at the time. I guess actually I should mention why I decided to get it, which was a big decision for me. Like I said, I went through all of the oral medications first, and I maxed out on all of them, and I still wasn't getting a substantial decrease in spasticity. And the spasticity wasn't insignificant or trivial in that I couldn't sleep at night because my legs would come up and in one case fall off the bed, and so I'd be hanging there, and it was just not good. I'd need someone that I could call every night, and so it was not conducive to good sleep or just just an active lifestyle. My legs would fall off my chair, because they'd kick things. So it was definitely it definitely made a huge impact in improving my quality of life. It wasn't all great though at first because I was really thin at the time when I first got it implanted, and also I have sensation all throughout my body, although it's not normal. So it was pretty painful having the incisions, and especially in the front. So when I would transfer and I'd lay supine, it would hurt because it would be kind of pulling the wound apart. But also some complications I had were in the back, since I was so thin, the catheter rubbed raw, or the metal port rubbed raw against my backrest, and so then I had to get a flap surgery and do all sorts of reconstructive routing of the catheter, and I had another hospital stay because of that. So these are things that might happen, but I still don't regret any of it because of the beneficial impact it had on my quality of life.
How many of you are still taking any oral medications in addition to the intrathecal medication?
I'm not taking any oral medications for spasticity.
I'm not taking any oral medication either, although twice I've gone through baclofen withdrawals. There was one time that I get my baclofen pump refilled every 4 months, and at the time the scheduling computer didn't go out far enough, so it was on my responsibility to schedule something a few months later, and I spaced it, and all of a sudden the pump went into alarm, where it does give an audible alarm, but it's very quiet, and honestly I thought I was hearing things, and it turns out it was the pump telling me that something was wrong. It didn't run completely dry. As it gets close to the very end, the rate slows down, so it doesn't go completely dry. Although the second time that I did go through baclofen withdrawals, there wasn't as much drug in the pump that the computer thought there was, so it ran it all the way completely dry. So in those situations, it would have been in my best interest to take oral baclofen, not to reduce, not like it wouldn't have prevented the withdrawals, but it would have helped quite a bit. I still would have had the spasticity, but it would have not been quite as extreme as it was.
And I don't take any oral baclofen anymore either. I do have, and if I can encourage you, I have one of the smaller pumps, because that's the one that my surgeon wanted to put in, and which means that I'm right now getting refilled every 4 weeks. So if you have a choice, get the bigger pump. It seems like it might not make a big difference, but it's a huge difference, and I wish that I would have done that.
So are any of you getting injections to complement the intrathecal baclofen? Any injections like botulinum toxin or anything like that? So none are requiring.
I'm not, although my neurologist has talked about it because I do have a little bit of spasticity in my hands, and since the pump works better on your legs, that we've talked about doing the Botox injection.
So is there anything that you wish you had known, now that you've had the pump implanted, is there anything that you wish you had known in advance prior to the pump being implanted that would help other people who might be considering the pump?
I wish I would have had this meeting. We didn't have this meeting. So I sat here with you guys and I learned a ton of stuff that I think that what the best thing is to really have realistic goals, because although Dr. Reyes was really good at telling me when I watched the video that's from the company and you see the people walking and being optimum and best, I don't think I had a completely realistic viewpoint. And even though the information was presented, I made my own conclusion of what it would be. So when I had to go to a wheelchair, it was harder for me because I didn't have a realistic view. Now I was never disappointed that I did the surgery, but my recovery time has been longer than I thought. But I think if I had a more realistic expectation, that wouldn't have happened.
Of the information that I know now, there's, hands down, I would still get the Baclofen pump. Although, one thing that has surprised me through the years is the significant increase in cost. My first pump was 13 years ago. I'm on my third pump. My first pump was 13 years ago, and then about 6 years later, I got a second one, and then 2 years ago, I got my third. And progressively, I can't remember what the surgery costs were originally, but certainly the cost of the refills has gone up dramatically. I think when I first started getting it refilled, it was closer to about $100, $150, covered by my insurance. Naturally, it was more than that. Insurance picked up quite a bit. About 3 years ago, it was closer to $250, $275. Now, recently, to refill my pump, which I do every 4 months, it's closer to $500. So, and that's with insurance covered, and that's good insurance. The actual surgery this last time around was closer to $30,000. Again, I was covered insurance, but they're big numbers. So, still, hands down, there's no way I would not go without having a pump. I mean, I love this thing. There's no way, like you were saying, that the quality of my life is dramatically increased. There's really no way I could go without it. But it is a financial, gulp at times.
I was lucky to have been an inpatient here, and so I had many of the doctors here to advise me on the potential drawbacks of the pump, and I also went through all of the oral medications, and so it wasn't like I was just jumping into this. I was kind of desperate in terms of trying to just sleep at night without having spasms, or trying to get through the day without my feet coming off my footrests. And so I don't know. I think the information today would have been really helpful. I would have probably ended up doing the same thing. Looking out for skin issues, I think, could be big, especially because it is a surgery, and especially on people like me who are thin or who are in wheelchairs, which most people with pumps might be for Baclofen anyway. That could cause all sorts of skin issues if your backrest isn't made right, or if you wear belts that are right around your belly. So you could just think about that and how it'll impact you. But again, like Billy, it's made a huge difference in my life, and I don't really think about it except for every 2 months when I get a refill. So I'd recommend it if it sounds right for you.
I'd like to ask one more question before we open it up to the audience. Yes, actually, we had cleared this with Billy in advance. He was actually willing to show his pump so you can see what it looks like from the outside, his body. So
I'm
just try not to flash everyone here.
I'm kind of thin, so it sticks out. So I guess I'm making a pretty good volunteer here. But it's just right there.
It's about the same for me.
It sticks out. I've got the smaller of the two, the 20 milliliter. I'll do the 40 milliliter. The 40 milliliter sticks out about another, I don't know how much bigger, but on this, actually, let me grab on this.
Oh,
real quick.
sorry.
For the third surgery, the doctor was really recommending me heavily to go to the 40 milliliter pump, just so I wouldn't have to come in so often to get it filled. Like I said, I come in about every 4 months, which is fine. I live in Seattle, which is also fine. I went with the 20 milliliter simply because being thin and it does stick out, it was worth it to me to go for the lower profile so it didn't stick out quite as far.
And then I think my last question is for Marie. I'll put Marie on the spot a little bit here. What have you seen from working with Allison in terms of, you saw her at the time of the assessment and the screening process, and then subsequently. And, I think, Allison, you shared with the audience that at first you were sort of doubting whether this was the right thing for you to have done, because it was a difficult change in your functional abilities, and then you sort of had different thoughts along the way, and Marie's been working with you with physical therapy. So what are you seeing as sort of changes in Allison's functional skills?
Well, I think Allison said, which is a very good point, that it's taken her a long time to kind of get the goals met that she had going into baclofen therapy. And I think that's something I've seen a lot, especially with people who are using their tone functionally. And Allison is one of those cases. And so we've definitely had our times of frustration, of Allison wishing she could do the things and functionally that she could do before she got her pump. And so, I mean, I guess what I've just witnessed with her is that it's taken us a lot longer to gain the strength back that she was using as tone before, so we've incrementally increased her baclofen as she gets stronger. And then what gets frustrating about that is that when she gets stronger, then we increase her baclofen dose, and so functionally she gets a little bit weaker again. And then we strengthen, and when she gets stronger, we increase her baclofen, and she gets a little bit weaker again. And the end result after many months has been that she is getting the strength to do the things that she could do before, and this time not so much with the tone and all the bad side effects of her tone, but more her strength and being able to function at that level. So there's been a lot of frustrations along the way as she's had to have more caregiving help, more help from her family, potentially even more difficulty in her home with transfers and safety. So it's been a long road, and I think that's kind of the key that we've discovered is that in order to meet her goals, it's taken a long time to meet them. But ultimately, and I know this about Allison, that she would do it again. And even when I've asked her if she had known this would be the road when she got her pump, would she have wanted to know this, first of all, that the outcome would be, being in her wheelchair and functioning at the level she had and the length of the road that it's been, would she still do it, knowing that at the beginning? And she still would. The outcomes are that beneficial for her.
Thanks. I want to give the audience a chance to ask questions if there are any questions that you have of the panelists or myself.
I have a question for Allison. I'm not sure maybe you mentioned this, but how long ago was your pump installed?
It was in April of '09, so yeah. And then I was in the hospital, and I did the inpatient rehab for a month after.
So I think the question was, what is the time course typically for when you first have a spinal cord injury to when you would consider intrathecal baclofen pump implantation? And there's no real answer to that. I mean, the general recommendation from the device manufacturer, particularly for those who have had a head injury, is to wait about a year. But I think in many ways that's a little bit of a misconception in the community that there's this period of time that you have to wait. Really, it's when you need it the most. And so that in some individuals that might be early on when you've tried everything else, you certainly want to give adequate opportunity for people to have natural recovery if it looks likely that if it seems likely that they're going to have some further motor recovery, so that you're not sort of changing so much at the same time. And because this is still an invasive procedure with potential risks, you don't want to expose people to unnecessary risks during a period of time that they're having significant motor recovery. Having said that, if the spasticity is getting in the way of volitional control of this movement that's coming back, then I think it's time to really reconsider that option. Well, the question has to do with how long it's taken Billy and Aditya to get to the sort of their ideal dose, and do you have any spasticity that was functional for you?
Right. There is still functional spasticity that I have in my upper body, mostly my my hands, so my fingers close enough so I could open doors with handles and grab things, and also if I need to use muscles that aren't very strong, the spasticity helps a little bit with that. And in terms of how long it took to get the right dosage, my spasticity was kind of increasing for a long time after I got out of the hospital. So as I was increasing the medication, my spasticity was also getting worse. So really, it's taken a few months at first to get it to a good level. And then my spasticity would go up, and then I'd be able to adjust, and then it would go up again, and I could adjust without maxing out at an oral limit.
And that's an important point in that certainly in the first year after your spinal cord injury, you can have continued evolution of tone and spasticity, and so you are sort of chasing what seems like a moving target.
In my case, I never use spasticity to help me. And to get the dose, I'm on a lower dose than I guess the average, I guess the median. So the dose that was chosen by the doctor during the surgery was already higher than I needed. So every time I got it refilled, I'd wean it back just a little bit just to find that threshold of where, spasms started to come back in the equation. You don't want to take those back. Interestingly enough, though, on my second surgery, I stuck with the same dosage and the same quantity each day. But on the third time I had the surgery, my quantity had to go up. It's all they did was they took the pump out and hooked it up to the same catheter, but for whatever reason the dosage had to go up. I can't explain that.
Did you have much recovery time after the pump was replaced?
No, just as for recovery for the surgeries, just the healing of the wound. That was it.
You can repeat the question.
If I had an MS exacerbation from the surgery itself, I did not have that. The only thing that was, I guess I could say, was negative is for the month that you're in the hospital, or however amount of time. With MS, of course, you want to keep everything moving and whatnot. I was sedentary a little bit too much. They do get you out twice a day for physical therapy. Well, once for physical therapy, one for occupational therapy. But other than that, that's 22 hours of sitting in a bed. And so that was not good for my MS, definitely. But that was the only down part, but I didn't have an exacerbation. One other thing I wanted to say, though, real quick, we haven't talked about, is for your caregiver. My husband's not here, but it's amazing how much easier he's able to move my legs, getting in the car, getting out of the car. So that's also a positive.
It sounds like we need to wrap up this session, but we'll be around for a little bit to answer questions from everyone.
I'd like to thank all of tonight's speakers for coming and speaking with us. Thank you.